Hello, and welcome to highlights from AUA 2025, Advances in NMIBC. We strive to offer educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. We thank you for joining us. Before we get started, we'd like to go over a few items. I'd like to extend a special thank you to our course director, Dr. Seema Porton, for her tremendous efforts to plan this activity. We thank you for your dedication and commitment to urologic education. Thank you as well to our distinguished faculty, Brandon Aruda, Kelly Bree, Petros Grievous, and Vignesh Pakiam, for their time, talent, and expertise. The AUA is accredited by the ACCME and designates this enduring material for a maximum of 1.0 AMA Category 1 credits. The AUA is not accredited to offer credit to participants who are not MDs or DOs. However, the AUA will issue documentation of participation that states that the activity was certified for AMA PRI Category 1 credit. All persons in a position to control the content of an AUA educational activity are required to disclose all relevant financial relationships with any ineligible company. Please visit the AUA University to view faculty, education council, and COI review workgroup disclosures. The AUA would like to thank Merck Co, Inc. and ImmunityBio, Inc. for providing independent educational grants in support of this activity. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted, and please follow individual insurers' rules. Thank you for attending highlights from AUA 2025. I will now turn the program over to Dr. Porton.
Thank you for joining today at Highlights from AUA 2025 to talk about advances in non-muscle invasive bladder cancer. My name is Seema Porton, and I'm an associate professor at UCSF, and I specialize primarily in the management of urothelial cancer, both non-muscle invasive and muscle invasive disease. I am honored to be able to moderate this timely discussion, and we have an excellent faculty here today with me. We're going to start off by everyone introducing themselves, and so we will start out with Mr. Brandon Aruda.
Hi, thank you so much for having me tonight. My name is John Brandon Aruda. I am a board-certified nurse practitioner and a board-certified urology nurse practitioner practicing at West Virginia University Medicine in Morgantown, West Virginia, primarily focused in adult urologic oncology and survivorship.
Next, we will have Dr. Kelly Bree introduce herself.
Thank you so much for having me tonight. It's a real honor. My name is Dr. Kelly Bree. I'm an assistant professor of urology at the University of Texas MD Anderson Cancer Center. And my clinical and research focus is also on urothelial cancer, both non-muscle invasive and muscle invasive disease.
Okay, Petros, you're up.
Great to see you, Dr. Porton, and everybody else. Thanks for having me. I'm Dr. Petros Grievous. I'm a medical oncologist and a professor at the University of Washington and Fairhurst Cancer Center in Seattle. I'm serving as the clinical director of the GU Medical Oncology Program. I focus a lot my research and my practice in patients with urothelial carcinoma, urinary tract cancers, and I'm very excited to be with you today. Thank you for having me.
Thanks, Petros. Vignesh, you want to introduce yourself?
Yes, also excited to be here. I'm Dr. Vig Pakiam. I am a urologic oncologist at Rutgers Cancer Institute and an associate professor here. And my main clinical and research focus is bladder cancer and upper tract urothelial cancer, specifically non-muscle invasive bladder cancer.
Okay, welcome to you all, and thanks again for joining me today. So I'm going to start out by defining the scope of the problem, and then we'll kind of move into our discussion. So non-muscle invasive bladder cancer, or NMIBC, accounts for about 75% of all new bladder cancers at diagnosis. The survival rate is indeed favorable. However, a high percentage of patients experience recurrence after initial treatment or can progress to MIBC, and a lot of our conversation will be on how to manage that. Non-muscle invasive bladder cancer is one of the most active areas of investigations in GU malignancies. AUA 2025 included a number of programs covering NMIBC, and our goal today is to discuss both new and current management for this disease. It was a bit of a banner year for bladder cancer in terms of new discoveries. So we're going to start out with our discussion with just the basics of bladder cancer. So as you look across the offerings at AUA 2025, one of the cornerstones in many of the instructional courses on this disease was in risk stratification. And this includes the non-muscle invasive bladder cancer treatment dilemmas course. I'll try to call out the different courses and plenaries that our discussion is geared towards. So if those who are tuning in want to then reference that on demand or later through the course paths, they are able to find that easily. So we're going to start with Dr. Bree. Can you set the stage in terms of risk classification and how we define this disease and the different disease states that we'll be talking about during this hour?
Yeah, absolutely. It's my pleasure. So I think as we talk about non-muscle invasive disease, having a really good understanding of the risk stratification is crucial. And so the AUA has three primary risk groups. Low risk patients are patients that present with a solitary, small, less than 3 centimeter, a low-grade TA tumor or pun lump. Intermediate risk patients are nearly all of the other low-grade TA patients. So patients that have had recurrence within a year, they have a large solitary tumor that's greater than 3 centimeters. They have multifocal disease. Per the guidelines, this also includes patients with low-grade T1 disease, as well as patients with small, high-grade TA disease, though I will say many of us that focus primarily on bladder cancer will treat these high-grade patients in a similar fashion to the high-risk patients that I'll mention here in a second. And so the high-risk risk group is patients with high-grade T1 disease, high-grade TA disease, either recurrent, large, multifocal, or as I mentioned before, many of us treat any high-grade TA tumor as high-risk disease. Patients with carcinoma in situ, those with high-grade disease that have received BCG before but have had BCG failure, patients with variant histology, lymphovascular invasion, or high-grade prostatic urethral involvement. Additionally, there's an important group of patients that has very high-risk disease that we term BCG-unresponsive. And so these are patients that have received BCG, and it could be a high-grade T1 patient who we do their initial cystoscopy after induction BCG, and they have recurrent high-grade T1 disease present. This can be a patient that has recurrent high-grade TA or T1 disease within 6 months of completing adequate BCG, or this can also be patients with persistent or recurrent carcinoma in situ that presents within 12 months of completion of adequate BCG therapy. And that receipt of adequate BCG is defined as receiving at least 5 of 6 induction doses and at least 2 of 3 maintenance doses or 2 of 6 repeat induction doses. And so as the various treatments for our patients with non-muscle invasive disease continue to expand, having a good understanding of this risk stratification, I think, is really crucial to make sure we're stratifying our patients appropriately and recommending the appropriate next step in treatment for them.
Thank you for that. Yeah, there's a lot of definitions and a lot of classifications that I think really become important as we talk about treatments and sequencing treatments. Dr. Packiam, of course, to properly risk stratify patients, we have to make sure that we sample the bladder appropriately. In the IBCG forum this year, I know you had an opportunity to talk about what does an optimal TURBT look like in 2025. Can you share your thoughts on that?
Yes. So the IBCG, they set it up as a debate, which was kind of a fun format to be able to go back and forth. And I had the unenviable task of going against Dr. Tyson, who's very slick speaker. We actually agreed with each other for our points for the sake of, but for the actual presentation, we did a debate. He was arguing that surgeon factors are important. I was arguing that technology factors are important. At the end of the day, they're both very important to do a good TURBT. Some of the things that he discussed were that you have to do a systematic resection that really starts even before you do the TURBT. Make sure to look at imaging, have a good plan of attack to do a safe and effective procedure. When you're in the actual procedure, there's been a lot of publications about this, but try to use a checklist and a systematic approach. Make sure that you always sample detrusor muscle, and more importantly, really get rid of the entire base underneath the tumor, especially if you're suspicious for T1 or muscle invasive disease. You want to control bleeding to make sure that that's not distracting you and causing you to do any unsafe maneuvers. Remove all of the visible lesions that you see and try not to leave anything behind. Ideally, you want to send specimens separately because it is important to categorize multifocal CIS or multifocal disease versus just sending one specimen altogether. Minimize char or cautery artifact. That's going to help your pathologist to give an accurate diagnosis. And, if you have the capability of taking pictures, it's great to have, photo evidence of, pre and post resection proximity to your ureteral orifices. So I agreed with all of those surgeon factors. My task on the debate was to talk about technology factors. So, in 2025, we do have kind of more modern resection technologies. You can use bipolar resection. You can, potentially use en bloc resection. These are strategies that can reduce the char and give you more accurate pathology with your resection and maybe improve the safety. And then I also talked about enhanced cystoscopy. There's a variety of different platforms out there. There's narrowband imaging. There's blue light cystoscopy. Both of these modalities are probably the more common ones that are used, and they have a lot of evidence that shows that you can increase detection rates and potentially decrease recurrence. So I think in 2025, if you have access to these technologies, it's kind of a good idea to use them. And in my practice, I utilize one of these technologies in almost all of my cystoscopies. And one little caveat to that is that over time, we're seeing our outcomes for non-muscle invasive bladder cancer improve, especially to therapies that are the same that we used 20 years ago. Like, BCG now is working much better than BCG 20 years ago. And I think a lot of that is due to better TURBT.
Yeah, I think that brings up a good point, is that taking care of the patient starts with that good TURBT. It's not a sexy operation, but it is definitely really important, and I think deserves the stage as it got in the forum. So Dr. Grievous, also in looking at risk stratification for patients with non-muscle invasive disease, a lot of patients worry about if their cancer is more aggressive, has spread. And so there was a few courses looking at role of imaging in terms of classifying these patients. I know in the metastatic setting, you employ a lot of different imaging techniques to help really risk stratify patients, but in non-muscle invasive disease, how do you suggest employing things like PET or MRI for staging?
Thanks, Sima. Great question, and I love the dialogue that happened. I think it's very important, as you said, to get the stage right in those patients, and we all know there are many challenges with the accurate clinical staging in patients with non-muscle invasive and muscle invasive bladder cancer, inherent to the suboptimal imaging we have in this disease. And we all know we're worried about understaging. That's why I think the TURBT that you just discussed with Vig and Kelly are very important to get adequate as much as possible staging in the bladder for the T stage. But to your point, the end stage is also important. There are a few patients out there with true non-muscle invasive bladder cancer who might have lymph node involvement, very few, but they may exist. So your question is very relevant. How do you optimize imaging use in those patients? I would say for both non-muscle invasive we discussed today, but also muscle-invasive disease. I think the best imaging we have so far, let's say the most common use is CT with IV contrast. CT urogram will get a delayed phase to look at the upper tract as well, and the IV contrast can help whenever possible. Of course, we have to look at the kidney function, make sure there's no allergic reaction to IV contrast, but that's the most commonly used imaging modality. Having said that, there are particular cases where an MRI of the pelvis can be very helpful, especially if you want to look in more detail in the bladder or in the pelvis to look at potential invasive component, and also when it comes to muscle invasive disease for potential resectable versus unresectable tumor. So MRI has use, I would say, case by case, not routinely, but I think in selected patients. And I would say that some of the barriers to broader use of MRI is interpretation, the readability. You need to have a specialized reader who can read the MRIs. Is less common than CT. So the scalability of that, and of course, rapid turnaround time, enough machines, enough radiologists to do that. In terms of, but I think it has a role in selected cases. The other component you mentioned is the PET CT. I think this has even less of a role in bladder cancer. We have seen data sets, for example, the PET Muse study by Dr. Schroeder in the University of Toronto looking at muscle-invasive bladder cancer specifically. And the PET Muse study showed that there may be some selected cases where PET CT might be of relevance. Again, some borderline lymph node scenarios, maybe cases with neuroendocrine diseases. Sometimes we think about PET scan, but in the PET Muse study, there was no significant difference in the outcome of patients with or without the use of PET CT. Having said that, there were probably some patients who were probably upstage with the use of the PET, and they had lower rates of local treatment like radical cystectomy. So there was some, I would say, impact on decision making, but case by case. So to overall conclude my thoughts, CT, abdomen, and pelvis with IV contrast is a routine test. There are selected cases can benefit from MRI, and maybe a few who may benefit from PET CT or PET MR, but I would say that it's not a routine test for now. It's probably limited use.
Thank you so much for that. I think now we can move the focus to the different disease states that Kelly kind of laid out for us. And so let's start with BCG-naive high-risk bladder cancer. So those are those high-risk patients who have not seen any treatment after TURBT. Mr. Arruda, at the Urologic Care for the Advanced Practice Provider Forum, you spoke about managing patients with bladder cancer. How do you manage patients with BCG-naive high-risk disease?
Well, yeah, that's a great question. And in this era of the unfortunate continued BCG shortage, it becomes much more of a challenge, right? So as we all know, first and foremost, it requires an amazing TURBT, which we've already spoken about how important it is to have that deep tissue sampling. And as we all know, our high-risk patients, if there's any susceptibility or concern that there's any upstaging in disease, we want to do a repeat TURBT within 4 to 6 weeks of the initial. But saying that we have all of that cleaned out and we have our high-risk disease status, really, the AUA guidelines still focus on BCG as the first and foremost treatment, right? Whereas, induction cycling for our patients we're still using it. It's been a struggle, over the last 4 to 5 years to find a BCG. That has really played a part in a lot of the amazing alternatives and innovations that we've seen in the bladder cancer and non-muscle invasive space. But really, in my practice, we still focus on, for our high-risk patients, and especially our high-risk CIS component patients, focusing them not even on a third or half-strength BCG, but really that full course, that full dose of BCG, at the very least, the induction phase. And if we can have enough, we really want to try to get them that 2 years of maintenance therapy. But again, it's very much of a challenge. Living and working in West Virginia, our patients travel 4 to 5 hours to get here, right? And if we're the only academic care center in the state, if we don't have BCG, nobody else really does. And it has posed challenges, but that's why we have great forums like this to sit and discuss, new innovations and new therapies that are coming that utilize BCG as that gold standard to really benchmark itself against. And so currently in our clinical practice, our high-risk BCG-naive patients will be offered induction BCG therapy if we have it available, and if not, then we do look at the alternatives of gemcitabine docetaxel.
Yeah, awesome. Thanks for bringing up all those important points in terms of access to care, managing shortages, and then also identifying a pretty high-risk patient group. And I think that provides a nice foray into one of the really interesting plenary presentations that was on Saturday morning at AUA in the practice-changing, paradigm-shifting clinical trials kind of section. Dr. Neil Shore talked about a phase 3 study called the CREST study. And I think it's really important that you bring up that CIS part, because I think it'll play a role as we discuss this study. Dr. Bree, why don't you kick us off and just share a brief overview of the data that was presented?
Of course. So as Dr. Porton mentioned, Dr. Neil Shore presented the results of the phase 3 CREST study. And so this was cysanlimab, which is a PD-1 inhibitor administered sub-Q, administered with BCG induction and BCG maintenance versus BCG induction followed by BCG maintenance. The results that were presented at AUA were just the arm A and arm C of the study. There was also an arm B looking at cysanlimab plus BCG induction alone, but we'll focus on the arm A and C cohorts. And so this is a BCG-naive, high-risk, non-muscle invasive bladder cancer study. So patients, as I mentioned before, with high-grade T1, high-grade TA, and or carcinoma in situ. Patients were randomized 1:1:1 amongst the 3 arms, and they were stratified by the presence or absence of carcinoma in situ. And the primary endpoint of the study was event-free survival. And so that was defined as recurrence of high-grade disease, progressive disease, persistence of CIS, or death from any cause. And the demographics between arm A and C were similar. Over half the patients had high-grade T1 disease. About a quarter had carcinoma in situ. Discontinuation rates between the 2 treatment arms were quite similar. And importantly, the primary endpoint of event-free survival was met, a hazard ratio of 0.68, or a 32% improvement in the combination arm that got cysanlimab plus BCG compared to standard BCG induction and maintenance therapy. I think some other important findings that Dr. Shore presented was that that benefit was consistent across different subgroups, so patients with CIS, as well as the patients with high-grade T1 disease. And when we specifically looked at patients with CIS, the probability of a continued complete response in that group was greater in the treatment arm, the cysanlimab plus BCG versus standard BCG. The treatment arm had a 92% complete response rate versus 68 at 36 months. And this is a group that is difficult to treat. And there's obviously a number of different agents in the BCG-unresponsive setting trying to address that, but really promising results. They also didn't note any differences in quality of life between the 2 groups.
Yeah, I think that's really kind of important. You know, this is new for urologists to some degree, right? Bringing in an agent that has systemic effect, even though you can give it subcutaneously. And so that's why it's great that Dr. Grivas is here too, in terms of, can you discuss a little about your experience with these immunotherapeutics, adverse event management, what you've kind of learned from sort of more advanced disease, and then the sub-Q dosing and your thoughts on that?
Thanks, Emma. Great discussion by Kelly, overview of the data that Neil presented nicely at AUA. You know, it's exciting to see that, you know, patients have options these days, and I'm really looking forward to more discussion about the CREST trial data that Kelly commented on, and also the Potomac trial data that will come up in the near future. As you pointed out, Sima, we have a lot of experience in the last decade in more advanced urothelial carcinoma and other cancer types with the systemic use of checkpoint inhibitors, intravenously so far. And I think the main, I would say, take-home points have been that we need to have a team, a very systematic approach for patient education, monitoring closely of the patient, and timely diagnosis and optimal management specifically, for immune-related adverse events. And I say that because if you look at the totality of the trials, depending on the duration of checkpoint inhibition, systemic exposure, maybe a proportion of patients between 15 and 20% that over time may develop let's say, severe grade 3 or 4 immune-related adverse event. And that's very, very important, as I mentioned, to recognize early and treat appropriately. So I'm all about, urology colleagues and friends. Of course, they have the capability of doing that, but they need resources. They need like a systematic approach, advanced practice providers, nursing team, pharmacists, to be available, to treat those patients. And I think that the practice will be interesting, and I think it may vary, maybe between LACPA sites and other community academic sites. If checkpoint inhibition is going to be used, and I put if because we have to wait for regulatory decisions, who is going to administer those agents? I think it's a great discussion to have. I think we have to keep an open mind, but we have to put some, of course, safeguards in terms of the infrastructure related to education and monitoring of patients. In addition to that, I want to say that the experience we have had so far is with intravenous checkpoint inhibition. Obviously, there is a significant interest with subcutaneous administration. This actually may have a number of advantages, and we can talk in another session more detail about pros and cons of each approach. Obviously, the one that comes to mind is that you free up infusion time. Right now, I know in many cancer centers, including ours, we try to expand our capacity and have more infusion space. So a subcutaneously administered checkpoint inhibitor can free up space and time there. Having said that, it's still nursing time in the clinic, right? The nursing should do that and, prepare the patient, the injection site, do the education, administer the subcutaneous injection. So it has to be, worked out in individual clinics, the workflows. I think that a risk of systemic side effects, is about the same between IV and sub-Q. So the logistics of administration may be, different. Again, free up infusion time with sub-Q. Having said that, what I mentioned before about the infrastructure and monitoring of patients and management of immune-related adverse events is the same for IV and sub-Q, are about the same. So I'm very interested to hear your thoughts, but I think overall, there are many options for the patients who have to work together to fine-tune workflows that work individually for each cancer center, community or academic. And of course, we have to, to think about patient selection. Who is the patient who may benefit, from that approach? I know, Sima, you and me talked about it a little bit at AUA, brainstorming about potential patient selection. And of course, all of that may result in a good problem, which is more patients being alive, so meaning more survivors and less patients dying from the disease. At the same time, that will create a more stress to the cancer centers, and we have to work together to meet that demand. That develop survivorship programs that I think John mentioned before, how we can help those patients not only live longer, which are amazing goal, but also live better and have a good quality of life.
Yeah, I think all those are great points, and particularly when looking at immune-related adverse events, right? Thyroid disorders are probably the most common when you look at the different trials across our bladder cancer space. They're low-grade ones, and that's not as scary, right? You get a lot of lab tests, and then you have to give some supplement. Of course, that's not something we do all the time, but it is something certainly I think that our practice might be able to learn. But that's a less scary one than a pneumonitis, right? Or a very bad colitis, myocarditis. Those are a little more rare. And so I think setting up that multidisciplinary team, like you were saying, we may need to learn from our colleagues who have a lot of experience in this and kind of figure that out. Dr. Packiam, if the FDA approves this, how are you going to use it? And then after that, I'm going to go over to Brandon and ask how he's going to operationalize something like this, particularly, with these differing patient populations, people being from far away, et cetera. So we'll start with Vig first.
Yeah, that's a really important question. Also a pretty polarizing question, I think. I think when we talked about some of the exciting updates from AUA, this was one where there's a lot of different strong viewpoints that are out there. In my personal opinion, I think that this should probably be used pretty selectively once it's approved. I don't think it's probably the right best therapy for all patients and all comers. There's a few reasons I think so. One, technically there was a statistical benefit in the combination therapy arm versus just BCG monotherapy, but it was a relatively small difference in my mind. This was a really well-powered study. There was over 350 patients in each arm. And when you have these big studies like this, you're powered to find relatively small differences. So, their primary outcome of event-free survival, the difference between the arms at 3 years was 7%, which I don't think is really a massive difference between the arms. That being said, when you look at the subgroup analysis in the forest plot, there were a few factors that were significantly different. Younger patients with CIS, patients with T1 disease tended to do better with the combination treatment compared to BCG, whereas the other subgroups tended to look similar. Now, a lot of these comparisons were underpowered, but looking at that, those are generally some factors that I would use to consider this treatment for younger patients with multifocal and aggressive disease. The other thing that I thought was interesting was that there was really no overall survival benefit in the arms. Maybe that would take more time to declare itself, but I think that's an important factor. There was significantly more toxicity in the combination treatment arm, more than 20% differential of grade 3 or greater adverse events. And I think that's really important when you have a variety of options to choose between. And, John mentioned this earlier, but, realistically, there is a BCG shortage. There may be other therapies that get approved in the future which do not rely on BCG in the first line setting. So I think that'll be interesting to consider in the future.
Yeah. And then, Mr. Aruda, this is even a more controversial question. How would you consider operationalizing this? You run a pretty big intravesical program for a group of patients who come very far. What are your kind of thoughts on that?
Polarizing at best. I love it. I think it's how we advance and we move the needle forward and we get better care for more patients more often. As I'm listening to everybody kind of give their impressions and their thoughts, I come back to what Dr. Agrivas had mentioned earlier about multidisciplinary, right? Because we all kind of live in our own little silos, so to speak, but that silo is a part of a bigger grain house. And when I'm practicing clinically, I have the privilege and the honor of being able to rub elbows with a medical oncologist, to be able to call downstairs and speak to a radiation oncologist, to have those folks in my back pocket to go, hey, let me run this XYZ by you. When we think about the community access problem, and we think about urologists and smaller private practices who may be wanting to initiate something like this, what is their comfort level? What is their skill set? What is their knowledge base? I mean, yes, giving a shot in the arm is not all that difficult. I've done it for 16 years, but being able to recognize the adverse events that fall into play, maybe something that's not bread and butter to the urologic provider, is something they do on their day-to-day basis. So listening to this, I love the idea of it being in the urology space, but it really gives me some thoughts about operationalizing it in an avenue of being able to say, what if there's some opportunities for telehealth services between doc to doc or advanced practice to advanced practice? What if we have academic institutions acting as a spoke and hub model to where they can have on-demand consultation with medical oncology, with with specialists who do PD-1 every single day in the intravenous setting. I've got Mr. Smith down in XYZ County. He's getting, BCG and sub-Q, and we run into a thyroid problem. Well, I've never seen it. Who do I call? What do I do? And I think operationally, my mind immediately goes to my rural remote patients and the practicing urologists and medical oncologists down there who are providing amazing care, but don't have that infrastructural resource available to them. That really, in my mind, especially post-COVID era, really brings into play, telehealth and teleconsults and building infrastructure where there may not be enough bodies at the building, but there's bodies around the state and around the region that can be a quick phone call, can be a quick consultation that can help walk a colleague through to learn, to teach, to grow until they have that comfort foundation level to where they're not feeling like it's a new space to them, if that makes sense.
Yeah, that's a really good point, and tools that we may have in place already in terms of helping manage patients as this disease space gets more complicated. And I think we'll pivot into talking a little bit about shortages, and then also about biomarker selection as possibly a way to help address this. Dr. Bree, I think Brandon touched on a couple of strategies in a BCG shortage, such as prioritizing the most high-risk patients and dose reductions. What other things were sort of talked about at AUA? There's a few instructional courses. Dr. Pohar had one on the management of NMIBC, but practical solutions for common problems. And this really was touched on extensively there. What are some things that you have implemented during a shortage?
Yeah, so it's a great question. And I think one of the first things that's important is really prioritizing the BCG for high-risk patients. So any patients with low-grade, intermediate-risk disease, giving those patients intravesical gemcitabine is my practice rather than using BCG in those patients. For the patients with high-risk, high-grade disease, prioritizing getting them induction therapy. If we need to reduce the dose, doing so, but really prioritizing our high-risk, high-grade patients. I think I'm really excited to hear the results of the bridge trial when that reads out. I think having additional agents in this space is critical. And obviously the retrospective studies and the small single institution prospective studies looking at gemdosi for BCG-naive patients are really promising. Patients tolerate the treatment really well. So I think this could be a great alternative that's well tolerated and also affordable, which is something that's different than many of the other agents that are coming down the pipeline for our patients with non-muscle invasive disease. I also think that there's interesting and exciting new novel delivery agents like the TAR device. How could something like that be implemented in our high-risk patients? There's a number of other trials looking at ways to modify BCG efficacy. Obviously, those require BCG, like the CREST trial, but if we potentially have a new, a different immunotherapy we're combining with BCG that really dramatically improves its efficacy, that would obviously help mitigate some of the issues with the shortage. So it's an exciting time to be in bladder cancer, and excited to see how our treatment paradigms change over the next couple of years.
Yeah, I mean, I think that parlays really nicely into looking at, are there any advances in biomarkers, right, in terms of selection of these different agents? And because currently, the AUA guidelines, the only thing that's sort of stated is using Eurovision FISH, right, as a way to assess, quote, BCG response, but nothing's really come into that predictive space. And there was a lot of urinary biomarkers touched upon in various poster sessions and abstracts like on Curia looking at prediction of BCG response, and Precedin and convergent UroAmp. So all these different urinary tests. But I think another exciting field is in pathology AI. And so Dr. Pakiam, I know you got a chance to present again at IBCG some data on this. And can you talk a little bit about AI biomarkers and selection in the first line therapy in these high-risk patients, specifically the VESTA test?
Yes, absolutely. So, part of the reason why we haven't had predictive biomarkers for BCG, even though we've been using BCG for, almost 50 years, is because until recently, we really haven't had another treatment that has similar efficacy to BCG. So there's been, dozens of clinical trials comparing BCG to single agent chemotherapy, where BCG pretty consistently outperforms them all. So, when we look at biomarkers that try to stratify response to BCG, it really seems to be prognostic because you're not comparing it to something else that has good efficacy. Recently, gemdosi has shown promising outcomes, like Dr. Bree mentioned. We have some pretty large retrospective multi-institutional studies, some small prospective studies, and we're excited to see the results of BRIDGE. But now that we have two treatments that are likely to have similar efficacy, it'll be really helpful to have a biomarker that can predict which patient is going to respond better to which treatment. So traditionally, we've used clinical pathologic features, age, sex, thought pathologic features, presence of CIS, T1 disease, multifocality. But, these have never really risk stratified patients completely, especially when you look at patients over time. What these AI tests are doing are they're essentially taking the pathology slide, they get digitized and then zoomed in at high magnification, 40x magnification, and then the AI model looks for microscopic features, over 700 in some of them, that are associated with the response to BCG. So the VESTA test is one of these that was developed. It was recently published in a multi-institutional study of over 10 centers where they developed and trained this model and then validated it on almost 1,000 patients and found that the test positivity could stratify patients that were more or less likely to respond to BCG. So that is prognostic. So then the question is it also predictive? Can you see if it's going to predict response better to BCG versus something else? And pretty hot off the press, this was published, really the night of right before AUA. We had another multi-institutional study, 2 centers, over 250 patients that were treatment naive, high-grade disease, and either received BCG or gemdosi. And what that study showed was that the biomarker, if it was positive, would predict a much poorer response to BCG compared to gemdosi. So, it was more than a 30% difference between the groups. And if the biomarker was negative, there was no significant difference in efficacy between the groups. It was almost identical at 2 years. So for the first time, it looks like there is a biomarker that actually may be predictive and it can help guide us to which treatment we can give, especially if we have a BCG shortage.
Yeah, that's really exciting. In number one, that there are going to be other options, hopefully, besides BCG once some of these trials result. But number two, that we're coming to a place where we have things that are predictive in terms of our biomarkers versus just prognostic, as you nicely outlined. I think next we should move on to another very hot topic at AUA 2025, which is looking at BCG-unresponsive bladder cancer treatment options. And so Dr. Bree, at the very beginning of our conversation here, defined that disease state, and all these different treatment options were discussed over multiple different sessions, including one of the plenary sessions that looked at that was titled Crossfire: Controversies in Urology. Dr. Pakiam, I'm going to go back to you as you participated in this session. I heard you give a great talk there. And when you kind of look at this disease space and BCG unresponsive disease, can you outline a few different treatment options both those that we commonly use, but also the newly approved FDA options.
So part of the reason why it's an exciting time for bladder cancer is that we have a slew of additional FDA-approved and off-label options that we can use in this setting. Historically, the only FDA-approved option was valrubicin, but it was very infrequently used because it's relatively toxic with pretty limited efficacy. In 2015, there was the first published report of gemdosi. So that's sequential administration of intravesical gemcitabine for 1 hour, followed by intravesical docetaxel for 1 hour. And after that was published in 2015, partially because there were no other good options that were out there for some time, this was pretty readily adopted by major academic centers and big community practices as well as a good option for patients that had recurrence after BCG. And there haven't been prospective studies in this space, but retrospective data pretty consistently shows that the 2-year complete response in patients with carcinoma in situ is somewhere around 50%. So this is pretty commonly used in the real world, and there's a lot of excitement about the regimen. In 2020, for the first time in 20 years, we had FDA approval of another agent, pembrolizumab. This is given intravenously, and this showed a anytime complete response of about 40%, 1-year complete response of 19%. There was a lot of excitement about this because this is the first agent that was published in a long time. I think it is used in select circumstances, especially immediately after FDA approval. Right now, maybe not as much, partially because of the adverse event profile. So there was greater than 10% rate of grade 3 or greater adverse events, which is a bit higher than a lot of the other purely intravesical therapy options that we have or that are in development. So for that reason, it's not commonly used at this time. Fast forward a few more years, and then we had approval of adstiladrin, which is an adenovirus that's instilled intravesically. This causes increased production of interferon, and it kind of makes the bladder into an interferon factory, is one way that I've heard it called. Really well tolerated. It's an intravesical therapy. It can cause a little bit of dysuria sometimes, but for the most part, a low rate of grade 3 or greater adverse events, well below 5%. The efficacy of this was a bit higher than pembrolizumab, anytime complete response over 50%, and the 1-year the 1-year complete response rate in the CIS population was 24%. So this was a very exciting therapy that was approved because it gives another intravesical agent, which has a better adverse event profile. The other unique thing about adstiladrin is that it is dosed at a really convenient schedule compared to almost any other therapy. So it's given quarterly, once every 3 months, which is a really big benefit for patients that have travel issues or have trouble retaining therapy. You really have to do a lot of work to keep that treatment retained for that one installation every 3 months, rather than the traditional once a week for 6 weeks. The year after that was approved, we had another agent, Anktiva, and that is an IL-15 superagonist that's combined with BCG. So really nice logistics because it's given just like BCG is, once a week for 6 weeks. You actually mix the medication with BCG itself and administer it just like you'd administer BCG. The efficacy of this was a bit higher, anytime complete response over 60%, and the 1-year complete response rate was 45%. Notably, their study did allow for reinduction with the agent if a patient had partial response or persistent CIS, which was not in the other studies that I mentioned, but still a promising kind of efficacy signal there. And the side effect profile was very good. Again, grade 3 or greater adverse events was well below 5%. Their study notably showed that many patients avoided cystectomy, about 90%, which was an important endpoint to look at as well. So those were kind of the new agents that were summarized, 3 recent FDA approvals, and then Gemdosi, which is heavily utilized in an off-label fashion.
Yeah, thank you for that nice summary. That it seems like there's a lot of options in ways of preserving the bladder. Brandon, how do you help patients figure out how to sequence therapy now that there are this many options? When BCG doesn't work, how do you choose? How do you help patients choose in figuring out what the next right agent is? I think Dr. Bree mentioned one thing, cost and affordability. But what are some of the other things that you've kind of implemented?
So when we think about how do we choose, right? What drug for what patient at what time and when and why, and it really comes down to that conversation, because with these high risk patients, they're traveling hours lots of times to get to the institution of choice. And obviously, we worry about, if they're treatment naive and we can give them BCG, obviously that's our gold standard. That is our choice. But, let's say they recur down the road. Let's say they have a recurrence. The question really becomes, did they recur with the same thing again? Was it CIS and then CIS again? Did they downgrade to maybe a low grade disease, or did they upgrade to a T1? We have to take that into consideration, because that plays a part as to whether or not you're going to offer your patients reinduction of BCG, or do we consider them a BCG failure? Do we then proceed to second line intravesical therapy with a gemcitabine, a docetaxel, or an Adstiladrin? Or unfortunately, do we have to start thinking about an upfront cystectomy? These are all conversations that we have to have in collaboration with the patients, looking at the fact that, not only does their disease come into play, but their other comorbidities and their other health issues also play a major part of it. Are they able physically to come back and forth for more intravesical therapy? Are they willing to take risks of cystectomy? Are they even surgical candidates for cystectomy? Those play big roles with my surgeons that I work with, because when we think about them, we can remove the bladder, but are we giving them a quality of life after that radical surgery that's going to provide them with good optimal years down the road? And I think ultimately what I do in my practice is it's usually multiple conversations. Once we get to that point where it's time to discuss sequential therapies, it's, have you had BCG? You failed. Okay. Do we do gemcitabine, docetaxel? Do we do Adstiladrin? Do we consider pembrolizumab? You don't want any of that. Do you want your bladder out? Well, if you don't want any of that, where do we stand? And unfortunately, it's never a cookie cutter, right? We don't practice in cookie cutter land, although I love cookies. We practice with real humans, real people, and individually those choices vary every 15 to 30 minutes with every new patient that walks in the door. And I think ultimately, if we as the providers, the clinicians, are providing them with the most recent cutting edge available options to them, whether it be at your facility or transitioning them to an academic institution that may have the resources and the opportunities to provide them with newer agents that may not be available to your center, I think ultimately that's best for patient care, and it gives them the opportunity to have that direct ability to influence their own healthcare, because ultimately, end of the day, it's their bodies that have to walk the journey.
I think that's a good point. It's actually a nice transition into another kind of abstract that was presented at the practice changing, paradigm shifting plenary session. And that is the results of the cysto trial. And I think this is a really nice foray into reminding us not to forget that we do have an effective surgical tool in addressing BCG-unresponsive disease. And I think it gave really great guidance on that quality of life aspect you were talking about as you're helping patients make this decision. Dr. Bree, can you talk a little bit about the key takeaways of the study?
Yeah, absolutely. So I think this was one of the most exciting abstracts that I got to see presented at AUA. This was work led by Dr. John Gore and Dr. Angie Smith, and it was a pragmatic study, prospective study of patients that were elected to either undergo radical cystectomy or bladder sparing therapy for their recurrent high-grade non-muscle invasive disease. In this space, it's really impossible for us to do a randomized control trial comparing the two because hardly any patients would consent to a trial like that where they're being randomized to bladder sparing or some major operation. So I think this is the best and really high quality data to help answer some of the questions that all our patients really want to know when they're considering how to proceed after they've received BCG and have recurrence. So the primary endpoint was of they were looking at various quality of life outcomes. The primary outcome was physical functioning. They also looked at generic quality of life, emotional well-being, financial well-being, urinary, sexual, bowel health, as well as some survival outcomes. And in terms of the primary endpoint, they found that there was no difference in physical function between patients who underwent radical cystectomy versus bladder sparing therapy. And in fact, in some of the patients with CIS and those who were unpartnered, physical function was actually superior in the radical cystectomy group. They also found that global health, emotional well-being, financial well-being were all better in the patients who underwent radical cystectomy. I think really highlighting how challenging the repeated cystoscopies, TURBTs, countless intravesical therapies, how taxing that really can be on the patient. Yes, they may have their bladder, but that doesn't mean that they're living the best quality of life spending hours each week in our urology clinics. The study did find that sexual and bowel quality of life was worse in the radical cystectomy group, which was not surprising. But I think many of us were really surprised by how much better many of the quality of life outcomes were in the patients electing radical cystectomy. And I think it gives us really great data to guide the discussions, which are often challenging in these patients who obviously are not excited about having their bladder removed. But it's a space we haven't had good data. And so really exciting results.
Yeah, I totally agree. I think it really helps us remember that perhaps this may indeed be the right option for the patient, especially as we're starting to get just a lot more agents and possibilities in that area. And so in the last couple of minutes, I just wanted to discuss two additional clinical trials that had results that were, again, presented in the same very exciting session in terms of bladder preservation in patients with BCG-unresponsive bladder cancer. So we're going to start with Dr. Grivas. Can you discuss a little bit about what Dr. Jacob presented regarding the Sunrise-1 study? And in particular, like some of the key takeaways, as well as, if you don't mind, touching upon later in that session what was presented from cohort 4 as well in that sort of realm and disease space.
Thank you, Sima. Great discussion, by the way. I really enjoy all the points by all of you. I'll try to keep it brief in this last session of our talk today. I was really interested to see the presentations by Dr. Jacob and also Dr. Guerrero Ramos at the AUA meeting. Really interesting to see the data from the Sunrise program, specifically the Sunrise 1 trial. As you mentioned, Sima, this trial had multiple cohorts, cohort 1, 2, 3, and 4. I think the key cohorts is with TAR-200 monotherapy, cohort 2 containing CIS, and cohort 4 papillary-only disease. And this, just to get the stage here for our audience, the Sunrise program evaluates an interesting what we call pretzel, an intravesical delivery of a chemotherapy, gemcitabine. Specifically, we heard from all great colleagues here about the sequential gemcitabine docetaxel chemotherapy that is given inside the bladder. This TAR-200 system takes that pretzel, and with a very interesting mechanism, it releases sustained release of gemcitabine inside the bladder, and that pretzel is being delivered. It's administered once every 3 weeks for the first 6 months, and then every 3 months thereafter. The Sunrise 1 trial particularly enrolled patients with ECOG PH0, 1, or 2 who had persistent or recurrent non-muscle invasive bladder cancer, BCG-unresponsive, within a year of completion of BCG. And I mention that because there's some variability in the definition of BCG-unresponsive and how trials define that, and I want to just point that out in terms of eligibility criteria. The cohort 2, as I mentioned, was TAR-200, again, the intravesical pretzel delivery of gemcitabine as monotherapy. That cohort had 85 patients, and about 2/3 had CIS only, and about a third had CIS plus papillary disease, TA or T1. The median number of prior BCG doses was about 12, and the median time from the last BCG to CIS diagnosis was about 3 months, and the majority of patients declined radical cystectomy. Relevant to what we discussed before for the cysto study, it's interesting to see that. Of course, this is a selected patient population enrolled before the cysto study was reported by John Gore and Andrew Smith and others. In terms of the primary endpoint, the overall clinical complete response rate at any time based on central review was 82%, quite impressive, I would argue. Pretty much 70 out of 85 patients had complete response at any time. And if you look at the actual observed overall clinical response rate at 1 year, was about 46%. And I say that we cannot compare across trials. It's impossible. There are different nuances and criteria and retreatment potentially, but numerically, this number that I just quoted compared favorably compared to the 1 year clinical complete response rate we saw with historical data from the nadofaragene study, the in NH03 interleukin 15 superagonist that Vic mentioned, and also the intravenous pembrolizumab. Again, we cannot compare across trials, a note of caution, but definitely a very impressive data set. The clinical complete response was noted regardless of the sex, male, female, tumor stage, and the BCG strain that was used before. And overall, the treatment was well tolerated, with mainly no significant side effects. If anything, most of them were grade 1, 2 urinary tract side effects as expected with intravesical therapies, but serious adverse events were fairly uncommon. Overall, very well tolerated treatment. I think we're all waiting to see what the regulatory agencies will do. FDA is reviewing the data with TAR-200, again, mainly from the cohort 2 monotherapy with TAR-200 in this CIS population. Very briefly, I want to point out, as you mentioned, that it was a separate presentation by Dr. Guerrero Ramos, the cohort 4, which is, again, patients with TAR-200 monotherapy, BCG-unresponsive again, but this is papillary-only disease. And specifically, if you break it down, 40% had T1, 60% had TA disease, no CIS, and the vast majority, 82%, declined radical cystectomy for this BCG-unresponsive papillary tumor. If you look at the data in a snapshot, you see the interesting curves with disease-free survival rate. If you take the 6-month time point, so at 6 months time point, the disease-free survival rate was 85% with TAR-200 monotherapy. if you look at the 9th month, disease-free survival rate was 81%. Median disease-free survival was not reached, and only about 6%, single-digit, 6% of patients underwent radical cystectomy. Treatment was well tolerated, as I mentioned. These data, again, are very promising. We have to see what the regulatory agencies will decide. The signal from disease-free survival, progression-free survival, and overall survival are very encouraging with relatively short follow-up. And of course, there are ongoing trials with that program, Sunrise 2, 3, 4, and 5. Sunrise 5 is comparing this TAR-200 monotherapy versus intravesical chemotherapy in patients with BCG-unresponsive or experienced papillary-only disease. So more to come from these very promising agents, and we'll see what the, again, regulatory agencies will react based on this data.
Yeah, I think it's very exciting times. And so, Dr. Packiam, I'm going to have you wrap up with one of the last presentations in that same plenary session by Dr. Mike Tyson, who presented the findings from the BOND study, and then we will wrap up our program.
Yeah, absolutely. So another very promising agent, BOND-3, is looking at an agent called cretostimogene, which is an oncolytic adenovirus. This specifically tries to target cells with RB pathway defects, which are upregulated in bladder cancer, and it causes increased production of GM-CSF, which is an inflammatory cytokine. It kills tumor cells both by direct tumor lysis from overproduction and from immune-mediated killing. So the BOND-3 study, it's a single-arm study, and there were a couple cohorts that had updated data reported. Cohort C looked at 110 patients that were evaluable with CIS plus or minus papillary disease, and they had updated results at AUA where the overall anytime complete response rate was 75%, which is impressive. 12-month complete response rate was 46%. And then I believe for the first time they showed 2-year complete response rate of 33%, which shows some durability of the agent. 85% of patients were able to avoid cystectomy at 2 years, which is also, like Dr. Grivas said, very important to patients. And this was a very well-tolerated medication. The grade 3 or greater adverse event profile was very low, less than 2%. They also reported some data from cohort P, which was just the papillary-only patients. This was a smaller subset that's still accruing. So they showed some interim results of 24 patients, and they had 9-year complete response rate reported, which was about 90%. So again, very promising. So another really well-tolerated agent that's showing some good efficacy signal.
Yeah, I mean, I think some key takeaways in terms of the wrap-up is that non-muscle invasive disease is a really exciting space, right? And I think this is going to be a hot topic at future AUAs as well, so more to come. Hopefully, we were able to give the audience some overview on current practice and then also some really new exciting things that are coming down the pipeline. And Drs. Bree, Grivas, Packiam, and Mr. Arruda, it was great to have you, and thank you for your time today in discussing this topic.
Thank you.
Absolutely. Thank you.
Thank you.